Good morning, everyone. Good morning, Dr. Percha. Welcome to Grand Rounds. This morning, we're very excited to welcome Dr. Beth Percha. She earned her PhD in biomedical informatics from Stanford University and her MPH in biostatistics and epidemiology from the University of Michigan. Prior to her role as data scientist and assistant professor in the departments of medicine and Department of Genetics and Genomic Sciences at Mount Sinai, she served as CTO of the Precision Health Enterprise, an applied research and product development group at Mount Sinai Health System, and also head of R&D Health Data and Design Innovation Center, which is Mount Sinai's first Silicon Valley outpost. She held the position of Vice President of Research and Development at Chiron, a venture-backed startup building a search engine for electronic medical records, and has been a consultant for many other health technology companies. Most recently, Dr. Percha and her team provided real-time admissions and census forecasts to the Mount Sinai Health System during the COVID-19 pandemic. Over the past academic year, she has also designed and taught modern clinical data science, a pilot course on machine learning and data science for medicine fellows. A very warm welcome to Dr. Beth Percha.
Great, thanks so much. And I'm really happy to be here. Let me just share my screen. Let's see. Okay, hopefully you can all see that. Yeah, so thanks very much. Great to be here. Here are my disclosures, non-relevant to this talk. So the work you're going to see today actually originated largely from a conversation that I had in early 2020 when I first joined the Department of Medicine with our chair of medicine, Barbara Murphy, around finding undiagnosed primary immunodeficiencies. So contrary to the talk announcement, I don't actually have an MD, so I had no idea what these were at the time. But for those who are like me, primary immunodeficiencies are when some component of your innate or adaptive immune system either doesn't work or isn't there. So you might not be able to manufacture a particular type of antibody, for example. And what's interesting about these is that they're often screened for and diagnosed in infancy, and so we catch them early. But it's becoming increasingly apparent that people can progress to adulthood and have one of these and just not know. They might get sick a lot, or they might have a particular type of cancer or infection. And so what Dr. Murphy and I were discussing was the potential of maybe finding people with undiagnosed PIDs from our electronic health record. So if you think about what that would look like, our electronic health record, you have different patients starting at different times, we see them with different frequencies, and we have different amounts of data on them, so it's a bit complicated. But the basic idea is that we would want to take patients who we knew had PIDs or we thought had PIDs and compare their records prior to their diagnosis to patients who did not. And we would let the computer figure out if there were patterns that indicated that the patient might have had a PID and maybe we could have caught it sooner. So this is the basic problem setup. And so, as many of you might know, we have PID experts here at Mount Sinai, people who have been working on this for decades already. And so one of the people that Dr. Murphy connected me with was Dr. Charlotte Cunningham-Rundles, who's a PID expert. And what she said was very interesting. She said that actually she had already built something like this in the early 2000s. It was called the STRIDE algorithm. And what she did was sit down with colleagues and come up with different diagnosis codes that were suspicious of a PID and assign scores to them. And then what you could do is go through a patient's record, tally up the score, and determine whether a patient was at high risk for having a PID. So a couple things about this, right? It's an expert-derived approach, and it kind of fell into disuse over the subsequent decades, although a similar algorithm is still in development at a private foundation. And the reasons for this weren't that it didn't work, they were actually more practical. One of them was that at the time, this was in pre-EPIC days, so they had to get special data dumps from MSDW and then load them. They could only process patients from certain physician practices. They would have to load these into Excel, do the algorithm manually, and then email the primary care physician with their scores. So it was pretty laborious. And then the second thing that happened was that coding practices changed over time. And in particular, we had to switch to ICD-10, which would have required rewriting some of the algorithm. So it was really for practical reasons that this technique still wasn't being used today at Mount Sinai. So what we discussed was, well, is it possible to actually replicate something like this using machine learning, since that was my area of expertise? And the basic idea behind machine learning, I'm actually going to talk quite a bit about machine learning in this talk later, but the high level picture is just that instead of building this algorithm manually, instead what you would do is you would take a set of patients who had a PID, grab their records and all the events that happened to them, get some controls, and let the computer learn whether there was a pattern that could distinguish the two. So effectively what machine learning does is it offloads the work that would have fallen to experts, to physicians, or the person running the project. It offloads that work onto the computer. And computers are very good at finding these types of patterns, and they don't get bored and whatnot. So what we set about doing was when you derive a machine learning algorithm, you need a training set. And so we did this. We built a data set that had patients' records, their diagnosis codes, pre-PID diagnosis, some controls, and then you would have an outcome that was whether or not the patient was a PID patient. So I'm drawing this here because this is what data look like for a lot of these problems. It's basically a spreadsheet, where you can think of it as one row per patient, and then all of the information about that patient that's the input to the algorithm across the columns, and then the outcome that you're trying to predict in a separate column, and you'd label it 1 or 0. So this setup is completely generic, and the type of problem I'm describing here, where we want to find a patient with a particular phenotype using machine learning, is called an electronic phenotyping problem. And the idea is that you can create weak labels on these patients through something like whether they had a PID diagnosis code, and then the algorithm will determine a set of predictors or features about the patient that indicate that they should have that code. So what you're trying to do is surface patients who look like the known PID patients, but don't actually have the code. And those are really the people that we're looking for who might have misdiagnoses. So what we did was build 4 different machine learning models using this training set. The exact details of them I'll talk a little bit about later, but it's not so important. What we did find is that any machine learning algorithm enabled us to basically double performance relative to an expert-derived algorithm that was similar to the one that Dr. Cunningham-Rundles had developed earlier. And so basically we found that we were able to save about twice as much pre-diagnosis time per patient learning from data as we could using an expert-derived algorithm. And the other thing that was interesting was that it didn't really matter what specific machine learning algorithm we used. All of them were able to learn these patterns effectively. So rather than focus on that, we should be focusing on, well, how do we efficiently train and deploy these algorithms? So what's useful about this approach? Well, obviously, it's great to see increased performance, right? And it's great to see that it could happen efficiently and from data. But there are some other practical advantages. One is that it's optimized for Mount Sinai's patient population and our own coding practices. We know that sometimes these models don't translate well between institutions, so we can build it here. That'll help us to know that it's going to be doing the best that it can on our own patients. It's really easy to retrain or update these models when you have changing data or coding practices, because again, you're offloading the work onto the computer to find these patterns. And then because the approach is completely agnostic, something similar could be applied to find other types of patients with different phenotypes. So this is all great, but I'm sure that those of you who have been following the media and have been hearing about machine learning for the past several years may be rolling your eyes a little bit, because we see stuff like this all the time, right? We see papers published all the time that say, I built a machine learning algorithm and it outperformed this expert system, hooray, it'll change medicine. And really we've seen in the last couple decades this exponential increase in the number of publications that use machine learning on medical problems, partially coinciding with the growth of electronic health record data. And very few of these ever get implemented. And actually in one of my very first conversations with Dr. Murphy, her line was something like, you guys build all this crap, but none of it ever gets implemented, which she was exactly right. So it's worth thinking about why that is. And there have been editorials written about how doctors aren't receptive to machine learning models and their black boxes and whatnot. But to me, I think it really comes down to cost benefit. when it's very expensive and difficult to train these models, when it requires specialized personnel, when it's hard to get data out of systems, and when it's hard to deploy them, then it's often not worth it in the end, or it's not perceived as being worth it. And so the question is, can we make this type of process really easy and seamless such that we can start to use machine learning in new ways as an exploratory tool? And that's what really excites me about being in this field, and what I want to talk more about with you today. So before we go on though, I guess partially due to my teaching orientation, I actually want to spend a little bit of time talking about what machine learning is and the specifics of some of these algorithms, because the term is so overloaded and often it's conflated with terms like AI, and it's just a mess. So to me, these are tools. They're useful for specific purposes, like a scalpel. And so it's worth thinking about what exactly the term means, because I think it'll help you all think about when and where this could be useful in your own work. So what is machine learning? Machine learning is when you have a computer learning how to perform a task by observing data rather than by being explicitly programmed. And the process that it uses to do that is typically a statistical algorithm. So if we can contrast this with traditional software engineering, like the kind that powers Microsoft Word or launches rockets or runs pacemakers. In those cases, there's absolutely no uncertainty. If the computer receives a particular type of input, it will produce the exact same output each time. But there's a broad class of problems and a growing class of problems, and a lot of them in healthcare, where it's actually useful to have the computer just examine data and tell us what the patterns are and sort of program itself. And this is really the class of problems that machine learning is good for. And I think, and a lot of people think, that electronic phenotyping is one of those situations. So just a little crash course on ML. I'm not going to get too deep into it now, obviously, but there are basically three types of machine learning. There's supervised learning, which is the type I just described, where you're learning a mapping between an input and an output, and the computer's learning that for you. There's unsupervised learning, where you just hand the computer a bunch of data and ask it to uncover some latent structure, such as clusters. If those of you who are familiar with PCA, that's an example of an unsupervised learning algorithm. And then there's reinforcement learning, which is kind of a different idea, where you don't have a fixed training set, but you have a learning agent that interacts with its environment and receives feedback and then improves its performance based on that feedback. So those of you who might be familiar with DeepMind's AlphaGo, that learned how to play Go really well and beat the world master, that system was trained using reinforcement learning. But one thing that's interesting or important to note is that in healthcare, 98%, I would estimate, of the problems that we care about can actually be represented as supervised learning problems. Basically, we're concerned with connecting predictors or potential causal factors to some kind of outcome that we care about, like mortality, survival time, et cetera. And so, when you're looking at this from a machine learning perspective, actually, most healthcare problems fall into a very similar framework, where you have this set of predictors or features that you care about, and you're using the algorithm to generate some kind of outcome. And in particular, the electronic phenotyping situation is a classification problem, where the outcome is a category. Does the patient have the phenotype or not? And so the whole goal of the machine learning algorithm is to create this mapping. And there are lots of different ways to do that. So one thing that people are often surprised to learn is that you all have been doing machine learning probably for most of your careers, or have at least been reading about it, because regression models, such as logistic regression, are actually machine learning algorithms. And I remember walking into my first day of machine learning class and having logistic regression be on the board and being very disappointed that we weren't learning how to build the Terminator, because actually this is an example of an algorithm that maps predictors to an outcome. We're not used to thinking of it that way, right? We're used to seeing tables like this in papers, where really what we do is we fit the model and then spend a lot of time interpreting the model coefficients or the numbers that go into that mapping, in terms of odds ratios and whatnot. But actually, the machinery of that model could also be used to make predictions. You could take a new patient with different features and predict, the probability of death or something from that. So logistic regression is machine learning, and it is one way of taking a bunch of information about predictors and mapping it into an outcome, in this case, a binary outcome, yes or no. So why don't we just use logistic regression for everything? Well, initially, let's say in the mid 20th century, or when folks were doing their first clinical studies, or when data-driven medicine was really starting, data sets were primarily collected for a specific purpose, and the collection of data was very expensive. So you'd end up with a relatively small data set with purpose-collected features. And in those types of cases, logistic regression models or related models like linear regression or Cox regression are completely appropriate. And there isn't really a need for this kind of heavyweight machine learning machinery. But what are we seeing now? We're now in a world where we have very large data sets, such as EHR data. Often these data are not collected for the purposes of any particular study. They might be collected for a totally different purpose, like billing. So you end up with a lot of noise in there, and predictors that are irrelevant or redundant or correlated. And sometimes when you're trying to solve a particular problem, you actually end up with a situation where you have, let's say, tens or hundreds of thousands of potential predictors, but not that many samples. So we're in this world of big, noisy data. And so what folks have done is to develop alternatives to models like logistic regression that can handle these big, noisy data sets. But what I want you to understand, and what I hope you come out of this talk understanding, is that none of them are doing anything that's substantively different. They're all still creating this map, learning this map from data. And it's the same basic process as these simpler models. So an example of an alternative to something like logistic regression would be a decision tree. This one in particular was trained using data from 569 patients, imaging features from fine needle aspirate images of 30 different imaging features. And then the tree was built to predict whether the breast mass was benign or malignant. And what you can see is that the tree was able to pick out the top features that it thought were important in making that prediction and just throw away the others. That kind of thing is much harder for a logistic regression model. And this is one of the ways in which trees can help. But obviously it's harder to report and publish and interpret a tree like that. As time has gone on and computing power has increased, we've also seen the advent of ensemble methods, which use these huge collections of learners, let's say a decision tree or a simple regression model, and enforce diversity such that each of them is being trained on a different subset of predictors or using a different subset of data. And so some names you might have heard are random forests or boosting algorithms. These are basically ways of creating diverse sets of predictors or models that perform that mapping in different ways and then letting them vote. And they'll often outperform a single model that's trained on, let's say, the whole data set. Other examples are, there have been folks who have tried to apply penalties to regression models to make them able to handle these large data sets and essentially chop out features that aren't important. And then neural networks or deep learning have been in the news a lot recently. It's a whole field, right? But the basic idea is, let's say you're stacking many layers of logistic regression like models together at a high level. So all of them are still doing the same task. And where these algorithms really shine is when you have a need for the algorithm to perform implicit feature selection, like we saw with the decision tree. When you have large numbers of features, many of which are irrelevant, when you want to learn, when you think there's some kind of complex interaction pattern among the features that is predicting the outcome, rather than simple relationships. But you pay a price for using these, and the price is largely interpretability, and the fact that fitting all these parameters and having these really flexible mappings is often very data hungry, and so the algorithms require more data. But we're in a world where we have more data. So the other thing I wanted to mention is that at this point, a lot of these algorithms for machine learning have been made available in open source packages, and it's very easy, if you know how to code, which obviously is a big if, to swap out different algorithms to do the same task. So in one line of code, you can often replace, let's say, a logistic regression model with a decision tree, and you can evaluate the performance of different models. So machine learning deployment isn't hard anymore. I don't want to act like it's not an area of active development, but we're at a point now where we should be able to use these models to do interesting things in healthcare from a practical perspective And we should be able to build software that can do this stuff. And really, it's not the machine learning technology that is the barrier there. It's more like data pipelines and software engineering, in my opinion. So we went back during the COVID-19 pandemic and started looking at the PID project and the work that we had done, and thinking about ways to do it more robustly so that we could start to apply the same methods to different phenotypes. And maybe even my personal goal would be to make this operational for something like registry building at our health system or some kind of value-based care initiative. Because it's not really that out there at this point. The machine learning algorithms work. We've seen them work on many different phenotypes. And the question is, how do we operationalize them? So if I look at our PID work with a critical eye, there were several features of it that would make it hard to replicate that work on new problems. One was we were using a custom data extract from MSDW. And so every time that we would want to update the model, we would need to request a new data extract, get it onto our Amazon Web Services computer, which was living in the cloud, which at that time was the way that we were storing HIPAA data, PHI. That server itself was expensive. So we were paying, let's say, $5,000 a year for that thing. And it wasn't even that fast. It was probably slightly faster than my laptop. So it's kind of in all of those aspects of the project were inefficient. Our code, to look at that with a critical eye, was research code. And that's most of the code that is used in these papers that are published about healthcare machine learning. For those who haven't coded, it's a little hard to explain, but basically there are many different ways to implement the same idea in code, and some of them are useful downstream and some of them aren't. So poorly written code can be correct, but actually really hard to use later. And ours, I would say, was medium. It wasn't great. And so basically the logic around the PID part of the model was merged with the logic around the machine learning. And that meant that we would have to rewrite a lot of stuff if we wanted to use it on a new phenotype. So that creates a high marginal cost, makes it harder to implement that on new phenotypes. So a couple of things happened during the pandemic that were actually good from our perspective. One of them was that we started doing a lot of operational work for the health system. And so as a result of that, got direct access to Epic. And so we're able to learn the back-end structure of these databases and how they worked and how to get data out of them in a way that could be updated whenever we needed it to. And the second thing that happened was that Minerva, our supercomputing cluster at Mount Sinai, became HIPAA compliant in fall. And for those who have not worked with Minerva, I'm not, if you know me, I'm a fairly cynical person. I'm not a fangirl about a lot of things, but I think Minerva is amazing. It is such a great resource. We're really lucky to have it at Sinai. It's basically thousands of computers stitched together. And it's fast, you can run hundreds of jobs in parallel, so you get things done that much faster. A lot of the computers that are part of the cluster are really good and fast and are state of the art. And they only charge you for data storage. So it really cut our costs. And so we switched everything over to Minerva when it became HIPAA compliant. And Max from my team actually wrote some code that just pulls data from Epic and puts it right on Minerva. So it's really efficient to start training these models, particularly for operational purposes or when they need to be updated frequently. So I would encourage you to look into Minerva. The second thing that we did was to start rethinking about our code and how we could turn it into something more generic. So right now, we re-engineered the code, and it basically will work on any phenotype at this point. So right now, the code has 3 basic functions. It'll do a summary of the population that you care about, and I'll show you what those graphs look like. It'll seamlessly train 4 different machine learning models to predict a particular phenotype and evaluate them using Monte Carlo cross-validation, which I'll mention in a second. And then once you're happy with your model, it'll train a final model and it'll rank every single patient at Mount Sinai using that algorithm. And so to do a new study on a new phenotype, the only things you have to do are define the inclusion and exclusion criteria. So what's your baseline population? And then what's the phenotype you're trying to detect? If you can do those 2 things, then we can just run this AutoML pipeline and build models and see if there's hope. So it enables this to happen really quickly. So just as an example, for something to show you today, I chose 10 different phenotypes, some of which we've already worked on, and some of which are new, and a couple of which I thought would be a little strange or unpredictable, like COVID-19 diagnosis and motor vehicle accident. But what I want to point out is that the entire pipeline of building phenotyping models for these patients, for all 10 of these, for 4 different machine learning models, ran in a single day on Minerva, because we were able to do everything in parallel and train and evaluate the models in parallel. That's why it's so incredible. So things that come out from the population summaries are the types of things that you would get out of slicer dicers. So this is not particularly novel, but it's nice to see it. So we provide that. So again, you can compare like the age distribution of the patients with your phenotype to the baseline. You can see for motor vehicle accident, we don't see a lot of people who are old or young driving, which is what we would expect. You can view the sex breakdown, self-reported, of the patients who have your phenotype. Race and ethnicity breakdown, again, self-reported. The year of first contact with the health system. This is something that is an interesting diagnostic, because we've seen a growth right in our patient population over time as we've acquired more practices and more hospitals. And so sometimes it's important to look and see when the patients you care about are coming in. So for COVID-19, obviously we saw some patients who had been with our health system for a while, but a lot of new folks. And then the other thing we provide is diagnostics around the duration of record per pre-phenotype for the phenotype. So this is important, and this is something that's pretty much universally overlooked in machine learning models, which is that you might be able to tell that a patient has a particular phenotype, but if that person isn't at your health system prior to that, it's not going to do them any good, because you have no opportunity to intervene. So it's often useful to look at how much record we typically have on these patients before they're diagnosed or they have their phenotype, so that we know, how much time we can save them by building a phenotyping model. And we also do this, we do this in both in calendar time and in the number of unique dates, because people come in more frequently or less frequently. So the software enables you also to seamlessly switch in and out different types of features that might be indicative of the phenotype. So currently we support different diagnoses, which we map between ICD-9 and ICD-10, labs, both whether the lab was conducted and whether it was normal or abnormal, medications at various levels of granularity, procedures, and basic patient demographics. And we'll be adding terms from the clinical notes, which is something I'm very excited about, because my actual primary research area is biomedical NLP. And it's stuff about hospital admissions, timings, et cetera. And eventually we want to get, a lot more data as well, but it's just a matter of prioritization. But what this allows you to do is, because you can train and evaluate these models so quickly, you can swap in and out different features and see how much they're affecting the outcome that you care about, the phenotype. Then the models are evaluated using a strategy called Monte Carlo cross-validation, where we randomly, once we built the training set, we randomly split it and train and evaluate on different subsets, and do this lots of times to get statistics on the performance metrics that we report. So the most common performance metric that is used to evaluate electronic phenotyping models and related models is the AUC, which is basically the probability that if you took all of your patients and ranked them according to the score provided by your model, it's the probability that a randomly chosen positive outcome person, a person with the phenotype, would be ranked higher than a randomly chosen control. So you can see here the effect of different feature sets on phenotyping models for these different conditions. And you can see in particular that, let's say that if you include race, it often increases performance, but it also increases the potential for bias. And we'll talk about that a little bit more later as well. So this allows you to kind of evaluate which features are important for predicting the phenotype in a seamless way. But AUC is not terribly useful in cases where the thing you're trying to predict is rare, because you can have a very high AUC, but still have a lot of false positives for any reasonable cutoff. And so we also provide precision recall curves that enable you to say, for example, that if you want to set your model cutoff such that you're capturing a certain fraction of patients with your desired phenotype, how many false positives will that cost you? And that's different for every condition. So we've done a lot of benchmarking for that for the PID experiments and others But you can build that curve for your phenotype, and it just comes out of the software. And then one thing we do that actually I've never seen done before is this concept of time saved, as I mentioned before, which is, if we ran this model at our health system with our patients, would we save them any pre-diagnosis time in terms of phenotyping? Would they get phenotyped before the physician noticed that they should be phenotyped? And so sometimes for conditions where the patient's being referred, or we just see them for the first time when they have that condition, we might be able to detect that they have it, but we won't be able to save them time, and the software can report that. So what's this useful for from an operational standpoint? To me, the most important thing about these types of phenotyping models is our capacity to build patient registries for different conditions easily, quickly, and update them. So you can imagine taking a phenotyping model for some phenotype, and then allowing the software to apply the trained model to every single patient at Mount Sinai. And then what's happening is that patients are being surfaced that we don't know have the phenotype, but that have a high score. That means that they look like other patients. The rest of their record looks like other patients with that phenotype. And so they should probably be included in cohorts or investigated further, and perhaps engaged with through some kind of care management, even though they don't actually have the label for the phenotype. So one of the things that's really interesting about this, there was actually an idea that came from Michelle Kim, so shout out to Michelle, a couple weeks ago, was this idea that we could actually use this model, or machine learning models, as a tool to investigate diagnostic bias. So if you examine the properties of the patients who are at the top of the list but are unknown to have the phenotype, are we seeing certain patterns? Like, for example, are we seeing that patients who are on Medicaid, let's say, are not receiving the code, but those who have private or Medicare insurance are? We can start asking questions like this because we know that the model was trained on features that didn't include insurance status, let's say. And you can imagine doing something similar for features like race. And so this is a line of research that I'm really excited about and would be happy to talk about further. So in terms of our software, our development plan is basically to try to get this, the big goal is to try to get the model turnaround time to under 1 week. So that would be defining the phenotype, defining the baseline population, running everything, and ranking everyone should happen in less than a week. I want to introduce some new code for building feature interpretation and shat plots, because one of the issues with these models is that it's hard to know what exactly is going on and how different features are affecting the model. So the shat plot just tells you what's the effect of a particular feature on an outcome in a way that is not dependent on the structure of the machine learning model. It's model agnostic. I also want to eventually, if there's interest and folks find this type of approach useful, implement different types of supervised learning algorithms, because it's basically the same framework. So you could imagine doing the same type of machine learning approach to predict something like survival, or time to event of some kind, or some quantity like a vital sign or a lab value. And way down the road, if we could hire a team of software engineers or get better at it ourselves, I would love to provide something like this as a service, perhaps working with the Mount Sinai data warehouse folks and scientific computing, just because there's no reason why we have to click run on these scripts and run them on Minerva. It could just be something that anyone could try to try to make machine learning cheap and easy, so we can start to think about how to use it for new problems. Okay, so I now want to revisit the primary immunodeficiency project briefly, because there were some updates since our initial development work. Basically, what we've done is we've built the final PID model using the new software. It's a gradient boosted decision tree model with 100 decision trees. So this is just one of the options in the software. We've trained it using a rather large subset of PID patients and controls. Notably, the model does not include race and ethnicity as a predictor. So I'll say why in a second. And then this final model was used to rank every single patient that Mount Sinai has ever seen, so millions and millions of people, and score them based on the likelihood that they have a PID. So this is very preliminary, but I did find last week that if you examine the patients if you just compare, well, take a step back. PIDs, one of the challenges with PIDs is that they're known to disproportionately affect white people. but it's not clear whether that's because there's actually higher prevalence or whether this is due to underdiagnosis among people of color. And so one of the ways we can start to investigate that is to look at the patients on our list and look at and consider patients with high scores versus low scores, and see if there's a difference between the patients who have a known PID and those who don't. And so this result is extremely preliminary, and I have a lot more investigation to do here, but basically if you look at the patients who are unknown, and you just compare patients who self-reported either Black or white race, for the unknown patients, there's an enrichment at the top of the list for Black patients. That association reverses when you look at the known patients. So what we might be seeing, what it seems like we might be seeing, is that when we start to go down this list, we're going to find people of color who did not receive a PID diagnosis, but really should have, or we should have been investigating that further. And so this is a tool, because the model is not built using race as a predictor, this is a tool that allows us to investigate that impact, which I'm really excited about. So the current status of this project is that we have collaborators at BioMe who are looking to see, sort of as a sanity check, whether patients with known PID causing mutations have higher machine learning model scores. So this could help us figure out, among the patients at BioMe, are we picking up, do our scores align with what we know about their genetics, sort of as a secondary validation. And then most excitingly, we just received IRB approval to begin recontacting and testing algorithmically identified suspected PID patients through a program that's run by my colleague Dusan Boganovich at the Center for Inborn Errors of Immunity. So we'll actually be, after some further work, reaching out to people who look like they might have a PID based on their diagnosis history and seeing if they do and what kind it is. So it would be amazing to go all the way from data to a newly diagnosed and treated PID patient. So just a few more comments. This is the section of the talk for everything that I wanted to tell you, but had nowhere else to put. So if this type of work is interesting to you, or you see a way that it could be used in your own line of work, or for your own projects, we would love to talk to you. We have an approved IRB that covers all of our work on electronic phenotyping, so we're allowed to explore and publish on different phenotypes, and we're always looking for new use cases. So there is a distinction, however, between work that's operational and work that's research, and I email Dr. Martin way too much about this because I obviously care about this, and it's very important to make sure that we're not overstepping the work that we're doing. So if your work's operational, like if you're building a registry and you want to use machine learning, or your goal is patient care, we're allowed to help you with that, and that does not require IRB oversight. So if you want to try machine learning on one of those questions, that's fine. But if your work's research, we would also love to help you, but you need to get your own IRB. And we do that for ourselves as well. So the PID project actually has its own IRB, because the alternative would be we were putting dozens of people on our IRB, and frankly, I don't want to be responsible for you. So we have language that we can help you write the IRB and maybe develop some kind of template down the road, but you'll need to get your own. For those who want to learn more about machine learning and what it can do, these are several great references that focus on code and how to develop machine learning models in Python, but are light on the theory. And I actually have some copies of this one if anyone wants a copy. If you really want to go deep in the rabbit hole, these are some books that are actually more about the theory behind some of these methods, and they're all great. I've mostly read all of them. If you're only going to read one paper, if you're, for example, familiar with the clinical research literature, you're more familiar with traditional statistics or biostatistics, and you want to get a sense of how the machine learning approach is different, I think the best paper is this one. It was actually written in the early 2000s by Leo Breiman, who's a professor at UC Berkeley. And he made this distinction between sort of the proto-ML people who were using things like neural nets and decision trees, and the more traditional statistics folks who are using regression models. And he's a little bit, he was a funny guy. He's a little derogatory, but it'll help you get a sense of how the thinking is different and how the thinking has been influenced by the modern availability of data and computing power. Particularly want to thank Dr. Murphy, who really was obviously you can tell from the talk, the origin of a lot of this work. and Cindy and Max from my team, who have helped me both building phenotypes and investigating phenotypes and doing coding. Our PID collaborators, folks who have provided advice for how to code up and understand different phenotypes. The scientific computing team has been amazing, especially helping us use Minerva. And then I want to thank my students from the pilot course I taught last year, who have seen, some of whom have seen a lot of these slides already, and had a lot of useful feedback for me that has helped me clarify how I explain this stuff. So that is actually the end of my talk. And I'm leaving you with this picture, which is actually a picture of a deep learning, a very modern and very sophisticated deep learning, machine learning model that was applied to classify images from the internet and classified this owl as a pineapple. So it just, this image, I love this image, and it helps remind me that, you know, our robot overlords are not here yet. So that is it, and I will take your questions.
Great, thank you, Dr. Percha. That was really very interesting. And I think we can check in the chat. Looks like someone put something in there.
Let's have a look. Hi, Tatiana, a name I recognize. Algorithms developed for disease identification here at Sinai can be generalized or implemented to other institutions. Would they need to have EPIC? What barriers do you foresee? Yeah, this is a great question, and it's one of the things that folks in the machine learning community talk about a lot. And actually, Dr. Kim and I just encountered in a grant that we wrote about machine learning for gastric cancer. Because yes, there is an issue. You can train a model at Mount Sinai, but if you think about the features it's using, what goes into your spreadsheet, those are formatted in a particular way, right? So for us, it'll be like a particular diagnosis, or let's say a particular ICD code, and physicians here use that code in a particular way. We don't really know if it's used the same way at other places at the same rate, or however they decide to do it. So if you think about how that would need to implement the same model elsewhere, you would need to have the data formatted in the same way, using the same feature identifiers to be able to make predictions on it. Otherwise, you'd be ignoring, you know, some of the features that don't match up with the features at Sinai. So one thing that's pretty much universally true is that these models don't perform as well at other institutions as on the data that they're trained on. That's almost universally true. But there are implementation issues as well, which is that it would be much easier if everybody was just using EPIC and everything were coded and stored the same. Then we could use the same model out of the box. In reality, what we have to do is essentially build adapters that help translate the data at somewhere else into the same format so that we can deploy the same model. So, you know, performance not guaranteed. They wouldn't necessarily need to have EPIC, but we would need to decide on how they were going to convert their features into something our model could use. How do you propose to validate the predictions from the Monte Carlo analysis? So the Monte Carlo analysis is giving us an estimate of all of the model performance parameters on our own data. So it's using data that's distinct from the model, from the data that the model's trained on, to evaluate it. And cross-validation is a traditional machine learning method for assessing model performance. So on our own data, that should give us a good estimate of performance. One potential issue, and one I've thought about a lot, but it's just so awful to think about that sometimes I ignore it, is how things change with time. So you could imagine that we could train a model. One way to kind of do an internal/external validation would be to train the model on data, let's say up to 2019, and then as our validation use data from 2020. Or we could do the same thing with different hospitals, data from different hospitals. We haven't implemented that yet, so I'm at this point taking the performance metrics from the Monte Carlo cross-validation as accurate, but there are different strategies. And so if that becomes important to a project, we can try to implement that. All right, Dr. Fetterman. Dr. Percha, thank you for your talk. Please speak about the challenge of identifying gold standards for training the ML algorithms. Yeah. Yes, how do you define, gold standards? Yeah, so one of the things with electronic phenotyping algorithms, typically the way that they're run is, as Dr. Fetterman says, you pick a labeling mechanism that's very specific or precise, but not necessarily very sensitive. And then you train the model to predict that outcome. So it has an element of circularity to it because you don't really have the right answer. You don't really have a label that's guaranteed to give you the phenotype. Otherwise, you wouldn't need to build the phenotyping algorithm. So the way this is a tough one as well. Probably the best and most common way to evaluate this would be to simply take your ranked list and have a human go to the patient record and evaluate some fraction of the patients at different score levels within the algorithm. We can't really avoid that if we want to be absolutely certain that we're picking up the phenotype today. There are resources like PKB out there that have collections of different phenotypes, but they're also built at particular institutions and are not guaranteed to get everyone here. And again, if they worked, we wouldn't need machine learning. So yeah, so this is the gold standard thing at this point. Typically, is going to be done by humans, particularly for the purposes of publishing. Are you also looking at the implementation science for these models? Developing an accurate model would seem to be the first component, with effective implementation being as important. Yeah. So if you want to know, if you want people who are battle hardened by all of this, go talk to the clinical data science folks, Robbie and Robbie Freeman and Matt Levin and their team, because they've had to deal with a lot of this in terms of real-time prediction. For patient registries, the pipeline seems to be that in Epic, it's possible to build a custom registry table. And that registry table can become a view on the database for anyone who uses Epic. So I think and plan to, in the end, once we've got this all figured out, essentially ship these scores to the Epic folks and have them implemented as some sort of registry table that then folks who are downstream, who are doing care management and stuff can use. So in some ways, the phenotyping problem is easier than other machine learning problems in this regard because it doesn't require real-time updating. You just process the patients and you can put the information back into Epic. So that's about as far as I've gotten with it. But I know that obviously getting people to use the output of the models is actually just as hard as, and probably harder than training the models. And that's one of the reasons that I wanted to give the talk now when the software is kind of new, so we can see who's interested in using these and what is the nature of the implementation for some of these models. Self-reported information is often incorrect. See Elizabeth Warren. Yes. Good point. Is this why you rejected race information? No, that actually wasn't why. It's because there's, so particularly for the PID thing, the PID project, we don't want to be learning. If we had included race, what the model would have learned is that it should give a higher score to white people. And the reason it would have learned that is that white people get diagnosed with PIDs more. And so it's essentially recapitulating likely biases in how we treat patients because it's learning from the data we already have. So by refusing to allow the model to look at race, it's learning from other features how to score the patient. And we can then see, is it picking up people of color more frequently than we do when we diagnose them? So it's really more that we don't want the model to actually be using race to score the patient in cases where that doesn't make sense. And PID is one of those cases. And the self-reporting is a problem. It's a challenge. The other thing that's challenging is that folks we didn't have as good or as complete of race information for earlier patients as we do for later patients. So we have to be careful about if we're seeing patients sooner or later, the rates at which they report race, that can also impact the model. The need to deconvolute the way in which the algorithm is making its judgments. Yeah, so one of the reasons why logistic regression and models like it have survived over a century at this point and are still in common use is because they're so interpretable. You can fit that model, you create that map, and each feature has a single number associated with it. That's how important it is to the model. And there's all this formalism and these hypothesis tests that you can do on these features to tell what's important to the model. And so regardless of whether the mapping is good or not, it's definitely interpretable. The machine learning community doesn't really have that, but there has been work done to build techniques for interpreting machine learning models, one of which are these chat plots that I mentioned earlier, which essentially look at the effect of different predictors on the prediction that the model is making. And so if a predictor has a strong effect on the model's predictions, you'll see that in that plot. So that's one of the things we want to start providing in the software. But one of the challenges is that when you're talking about big decision tree models, actually the same predictor at different places in different trees can have different effects. So you might have it increasing the risk of the outcome in one spot in one tree and decreasing it in another. So it becomes really complicated, and it becomes hard to assign a single number or interpret a feature across all those trees in the same way. That's why this is challenging. Can you talk about the specificity of ML phenotyping for unstructured variables? I'm not sure. Do you mean variables that are not captured in like coded data? Yes. Okay. Yeah. So extracting, and this is actually, I'll put a little plug in. I actually just wrote a review article on clinical text mining. It's called Modern Clinical Text Mining. So I've done a lot of research and updating my thinking about clinical text mining. And one of the things that's very apparent is that for a lot of the work we want to do, the outcomes that we care about predicting are actually things that are captured in text mostly. So that would be a lot of symptoms, patients, socioeconomic situations are in there, the outcomes of treatments in particular, did this thing work or not? So yeah, there is a lot in the EHR that isn't really captured in coded or structured information. Unfortunately, text mining is still, contrary to what you might see in the media, in its infancy. However, there are good systems like CTAKes or MetaMap that allow you to go through clinical text and tag concepts. And they recognize pretty much all of the concepts that are found in the, let's say, the Unified Medical Language System or UMLS. So I think as a first approach, we'll try tagging every note with those concepts and seeing if we can start to use those for prediction. But that problem is like an order of magnitude harder than using structured data, which at least we know is being collected in a semi-consistent way. Yeah, text is really, really fascinating and really, really hard. That's why I like working on it. Does anyone else have any questions? So basically, if you're interested in talking to us more about this, or you have a project idea, feel free to email me, and we can help you get started with an IRB. We have a lot of language around Minerva. We can help you set up an account on Minerva if you want to go that way, or figure out how to code if you want to go that way. So really happy to have more collaborations in this area.
Thank you, Dr. Percha. I can tell you from all the questions that people really enjoyed your talk. We had a lot of engagement today. So it was really great. Great to have you show us all your good work, and hopefully you'll keep doing more with us. So
thanks,
yeah.
everyone.
Thanks, Beth. Have a good day, everybody.
Bye.
Have a nice day. See you all.